Good morning, one and all. We will continue with the lecture on trauma. Last class, we had completed the luxation in fractures. Today, we will continue with the luxation injuries. The first one seems to be concussion. Concussion, by definition, is the injury to the tooth supporting structures without abnormal loosening or displacement of the tooth. How do you diagnose it? The diagnosis is, since the periodontal fibers ligament absorbs the injury and is inflamed, clinical findings reveal a tooth tended to percussion and without mobility, displacement, or circular movement. Okay, radiographic abnormalities are not expected. Treatment objective is to optimize healing of the periodontal ligament and maintain pulp vitality. For primary teeth, unless associated with infection, no pulp therapy is indicated. Although there is minimal risk for pulp necrosis, mature permanent teeth, closed epiphyses may undergo pulp necrosis due to associated injuries to the blood vessels at the apex and therefore must be followed up carefully, which means that you will have to recall the patient back after 2 weeks to do a pulp test. The tooth can develop periapical abscess or can discolor, which indicates pulp necrosis, because in a closed apex tooth, the neurovascular bundle enters through a very small orifice at the apex of the tooth and can sever off due to the trauma. Next is subluxation. That by definition, subluxation is the injury to the tooth supporting structures with abnormal loosening but without tooth displacement. How do you diagnose it? Because the periodontal ligament attempts to absorb the injury, clinical findings reveal a mobile tooth without displacement that may or may not have circular bleeding. Here also, radiographic abnormalities are not expected because there is no displacement. Sometimes there might be circular bleeding. Treatment objectives is to optimize healing of the periodontal ligament and the neurovascular supply. Primary teeth should be followed up for pathologic changes. Permanent teeth, you should stabilize the tooth by a splint and relieve any crucial interferences and splint for not more than 2 weeks. By the time, the pulp and the periodontal ligaments would heal. But you will have to recall the patient like in case of concussion and do a vitality test. Prognosis is usually favorable. A primary tooth should return to normal within 2 weeks. Mature permanent teeth with closed epiphyses, as in case of concussion, may undergo pulp necrosis due to associated injuries to the blood vessels and the apex and therefore must be followed up carefully. So a pulp vitality test is a mandate after 2 weeks. Then comes lateral luxation. Lateral luxation means displacement of the tooth in a lateral direction than axial. The periodontal ligament is torn and contusion or fracture of the supporting alveolar bone occurs in lateral luxation. Diagnosis is the clinical findings reveal that a tooth structure is displaced laterally, with the crown usually in the palatal or lingual direction if the traumas or the impact is from the front direction and may be locked firmly in this new position. The tooth usually is not mobile or tender to touch. Lateral luxation, radiographically, radiographic findings reveal an increase in the periodontal ligament space and displacement of the apex towards or through the labial bone plate. This is a picture of extreme lateral luxation where the tooth is almost in a horizontal position. Treatment objectives is to, in case of primary teeth, to allow passive repositioning if it is very mild, or actively reposition and splint for 1 to 2 weeks to allow healing, except when the injury is severe or the tooth is nearing exfoliation, in which case you will extract the tooth. So if it is minimal, you can allow passive repositioning, or if it is not minimal displacement, then you can actively reposition with finger pressure and splint it for 1 to 2 weeks for healing. In case of permanent teeth, reposition as soon as possible and stabilize the tooth in its anatomically correct position to optimize healing of the periodontal ligament and neurovascular supply while maintaining aesthetic and functional integrity. As soon as possible, one should replace or reposition the tooth. Reposition of the tooth is done with little force and digital pressure. The tooth may need to be extruded to free apical lock in the cortical bone plate. If the tooth is locked inside the bone, then you have to be extremely cautious in extruding it or trying to reposition it, because there is a possibility of you extracting it inadvertently. Splinting an additional 2 to 4 weeks may be needed with breakdown of marginal. Ideally 1 to 2 weeks, but if there is a breakdown of marginal bone, I'm emphasizing it, splinting an additional 2 to 4 weeks may be needed. Lateral excision, the general prognosis in case of primary teeth that requires repositioning have an increased risk of developing pulp necrosis compared to teeth that are left to spontaneously reposition. In mature permanent teeth with closed apices, there is considerable risk for pulp necrosis and progressive root resorption. Next injury is intrusion. By definition, it is the apical displacement of the tooth into the alveolar. The tooth is moved apically into the alveolar. The tooth is driven into the socket, compressing the peroneal ligament, and commonly causes a crushing fracture of the alveolar socket. How do you diagnose it? Clinical findings reveal that the tooth appears to be shortened, or in severe cases where the tooth is completely been intruded, it may appear missing. In such situation, identification is done through a radiograph. You can see the tooth completely intruded and is inside the alveolar. Tooth apex usually is displaced labially toward or through the labial bone plate in primary teeth and driven into the alveolar process in permanent teeth. This is because the primary teeth will have permanent tooth bud behind it. So it can come out through the labial bone plate in primary teeth. And in case of permanent tooth, since there is nothing else preventing it from being driven into the alveolar process, it goes inside the alveolar process. The tooth usually is not mobile in intrusion. Radiographic findings reveal that the tooth appears displaced apically and peroneal ligament space is not continuous. Determination of the relationship of an intruded primary tooth with the follicle of the succedaneous tooth is mandatory. You can see that the relationship of the permanent tooth bud and the root of the primary tooth. It is the permanent tooth bud, like in this case, lies immediately behind the primary tooth root. So if there is an intrusion, the chances of the permanent tooth bud getting injured is very likely, which you will have to inform the patient. If the apex is displaced labially, the apical tip can be seen radiographically with the tooth appearing shorter than the contralateral tooth. If the apex is displaced parallelly towards permanent tooth germ, the apical tip cannot be seen radiographically and tooth appears elongated. An extraoral radiograph also can be used to detect the displacement of apex towards or through the labial. So basically you have to see whether the permanent tooth bud has been damaged or not. An intruded young permanent tooth may mimic an erupting tooth. In case of primary teeth, the treatment objective is to allow spontaneous re-eruption except when displaced into the developing successor. In that case, you will have to extract the primary tooth. Extraction is indicated when apex is displaced towards the permanent tooth. In case of permanent teeth, reposition passively or actively and stabilize the tooth in its anatomically correct position to optimize healing of the peroneal ligament and neurovascular supply while maintaining aesthetic and functional integrity. In teeth with immature root formation, the objective is to allow for spontaneous eruption. In mature teeth, the goal is to reposition the tooth with orthodontic or surgical extrusion and initiate endodontic treatment within the first 3 weeks of traumatic incidents. In primary teeth, 90% of the intruded teeth will re-erupt spontaneously within 2 to 6 months. Ankylosis may occur, however, if the peroneal ligament of the affected tooth was severely damaged, thereby delaying or altering the eruption of the permanent successor. These things have to be informed to the parent, and these cases need periodic record and review. In mature permanent teeth with closed apices, there is considerable risk for pulp necrosis and progressive root resorption. Next injury is extrusion. By definition, extrusion is the partial displacement of the tooth axially from the socket. The periodontal ligament is usually torn. Clinical findings reveal that the tooth appears elongated and is mobile. This is seen in tooth fractures also. So you will have to make a radiograph to confirm your diagnosis. Radiographic findings reveal an increased periodontal ligament space apically, which will be usually filled with blood. Primary teeth reposition and allow for healing, except when there is an indication for extraction. That is, if there is a root resorption and the longevity of the tooth is not great, you can think about extraction. That is, injury is severe and the tooth is nearing exfoliation. If the decision is to reposition and stabilize, clean for 1 to 2 weeks. While repositioning, you will have to dislodge the clot that is formed inside above the apex of the tooth with finger pressure and position it to the right anatomic position before splitting it for 1 to 2 weeks. In case of permanent teeth, again, reposition as soon as possible and then to stabilize the tooth in its anatomically correct position to optimize healing of the periodontal ligament and neurovascular supply while maintaining aesthetic and functional integrity of the tooth. Repositioning may be accomplished with slow and steady apical pressure to gradually displace clot formed between the root apex and the floor of the socket. Splint for up to 3 weeks in case of extrusion. General prognosis, there is a lack of clinical studies evaluating the reposition of extruded primary teeth. In mature permanent teeth with closed epicents, there is considerable risk for pulp necrosis. These teeth might be followed up carefully. Finally is the avulsion. Avulsion, by definition, is the complete displacement of tooth out of socket. The periodontal ligament is severed and fracture of the alveolus may occur. Clinical and radiographic findings reveal that tooth is not present in the socket. History of tooth already has been replanted, has to be checked because in some cases where the individual knows that it can be replanted, sometimes they might replant it. So instead of thinking that it is an extrusion or something, you will have to take the history and ask if the tooth has been replanted or not. Radiographic assessment will verify that the tooth is not intruded and when the tooth is not usually found. That is, in complete intrusion, the clinical situation can mimic an avulsion. Treatment objective is to prevent further injury to the developing successor. Avulsed primary teeth should not be replanted because of the potential for subsequent damage to the developing permanent tooth germs. There can be infection, there can be ankylosis. So avulsed primary teeth usually are not replanted. Permanent teeth, you have to replant as soon as possible and then to stabilize the replanted tooth in its anatomically correct position to optimize healing of the periodontal ligament and neurovascular supply while maintaining aesthetic and functional integrity. Flexible splinting is suggested because otherwise the possibility of ankylosis is very high. So a flexible splinting for 1 week is indicated. Tetanus prophylaxis needs to be checked because if the tooth falls on a dirty area, the possibility of the individual developing tetanus is there. So you have to use a tetanus check for the tetanus prophylaxis, whether long-term immunity is there. In case if it is not there, an anti-tetanus toxoid can be given. Antibiotic coverage should be considered. Contraindications to tooth replantations. In certain conditions, don't replant the tooth. What are those conditions? Immunocompromised patients, because their immunity is compromised, introducing something like a foreign body is not advised. Congenital cardiac disorders, where there is a possibility of infective endocarditis, you don't replant. Uncontrolled seizure disorders can cause these reimplanted tooth from being dislodged from the socket and can be an object for aspiration. So, in uncontrolled seizure disorder, also replanting is not suggested. Mental disability, where the individual can pry the tooth out because of discomfort, also is a possibility. Uncontrolled diabetes, where possibility of infection and healing is compromised, again you don't replant. Age stage of dental development. Risk of ankylosis when considerable alveolar growth has to take place. Usually, we will differ from replanting if the 15 minutes extra oral dry time has exceeded. Compromised integrity of the avulse tooth on supporting tissues or lack of alveolar integrity. In such situations, you will not be able to replant properly. That is, if the socket is completely crushed and all that, it is better not to replant. Prognosis in a permanent dentition is primarily dependent upon the formation of wound development and extraoral dry time. If the tooth has got an open apex and is replanted immediately, revascularization will happen, and it is got very good prognosis. If the extraoral dry time has exceeded 15 minutes, then the possibility of tooth going non-vital and being rejected is very high. The tooth has best prognosis if replanted immediately. If the tooth cannot be replanted within 5 minutes, it should be stored in a medium that will help maintain vitality of the periodontal ligament fibers. The risk of ankylosis increases significantly with the extraoral dry time of 15 minutes. Transportation media for avulse teeth include, in the order of preference, Biospan, which is commercial transportation media, Hans Ballet salt solution, which is a full tissue culture media, whole milk, saliva, physiologic saline, or water. An elective endodontic treatment is done for teeth which are avulsed because there is a definite chance of tooth going non-vital in case of tooth with closed apices. Thank you.